welcome to the AI rounds. And this has been a really successful and exciting series. And I think for Bo and Kelly, one of the more interesting things is we're getting to learn so much about what is going on at UHN in the sphere of AI and what clinicians and scientists are doing. And I think it'll also enable us to figure out what we can do together. So today, Dr. Andrew Hope is going to speak on implementing AI in the clinic. Andrew is a clinician investigator in the radiation medicine program at Princess Margaret and UHN, an associate professor in the Department of Radiation Oncology at U of T. His primary research goal has been to understand the relationships between radiation treatment and the resultant normal tissue toxicities, which is interesting because he always tells me that radiation doesn't cause any toxicity to anything.
Only after surgery. Only after surgery.
Only after surgery, right? We both work in thoracic malignancies, and he specializes in treating tumors of the thorax and the head and neck. With that, Drew, thanks for joining us, and I'll hand the podium over to you.
Thanks so much. So thanks, Jeff, and Kelly, for the invitation. I was asked to give this talk kind of in a general talk on whatever you want. And so I basically made this into a soapbox in some ways. I'm going to try to advocate for what I think we need to be doing as an institution, as well as to try to give some examples of things that we should be thinking about as we're going toward this future vision of AI as a fundamental component of what we're doing in the clinics. So I always have to do the disclosures. So we have funding from the Foundation, CHR, Cancer Digital Intelligence, and U of T, and unrelated funding from drug companies for stuff outside of this work. This is the required web comic that you should all read. I think this is arguably one of the funnier takes on AI talks that I've ever read. It's on one hand, there are several positive sides. On the other hand, there are several malignant aspects we should be aware of. In conclusion, AI is here to stay. This has been every AI talk ever. I'm an expert. So fundamentally, this is, I think, what many people have approached AI talks is, the plus minus and, blah, 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 blah. But I really think that these sorts of talks, or this kind of concept of a talk, is a superficial view. And I really think that getting down to the nitty gritty of how we're going to actually deploy this is probably a more relevant exploration. And so I think there's really two things we need to think about when we're talking about implementing AI in the clinic. We really need evidence and infrastructure. And I think the sorts of questions we talk about with evidence are what sort of evidence, what is enough evidence, and how do we get the evidence? And that naturally, in some ways, leads to the infrastructure question: is where do the models live in the clinical environment? How do we access the relevant clinical data? Can this data be accessed in a relevant time frame? And how do you notify and inform the medical team about the results? And I think the problem is that these two things are so inherently interlinked that they oftentimes play off each other. And I wanted to kind of explore this a little bit with some use cases and some examples. But I think that this is what we really have to be thinking about as an institution: is how we're going to build a system that allows both of these things to happen in a clear and efficient way, and allows the people who are doing the hard AI science, the computer science side of things, to interface cleanly with the medical environment such that we can test and deploy these things in a useful way. So for those of you who don't do AI, I'm obliged to put in the what is the AI slide, which includes, the fact that we're trying to mimic human intelligence. There's variations and subsets of this that include machine learning, and more recently, the deep learning aspects, which uses all the stuff that we care about most now, which is tons of data and tons of crunch, where we can self-learn from large piles of data to extrapolate features of interest and generate models that will allow us to self-learn information that we care about. This has been AI for Dummies, brought to you by me. But fundamentally, if you don't have this background, of some of the stuff I'm going to talk about doesn't make much sense. We've all heard the AI story, kind of 2015, 16 is when we really started to hear about, AIs stomping humans in many of the domains where they previously thought to be impossible to do so. This was the AlphaGo story back in 2016, where Lee Sedol, who was, one of the world experts in Go, got completely just mega stomped by AlphaGo at the time. They've subsequently found some holes in AlphaGo, but it's been an interesting exploration. The thing about medical AI is that it's very different than this sort of AI, where you have a complete understanding of the state. Medical AI is very different. Like if I'm doing a malignancy specific AI and I'm focusing on overall survival, I'm only seeing a part of the board that drives overall survival. The malignancy may be a part of it, but it may also be cardiac disease. And those two things may interact because my treatments may make the cardiac disease worse. There may be genetic components that predispose people to both malignancy and cardiac disease. But there's also socioeconomic factors that are just poorly included in any of our data and any of our models. And then there's, of course, that speeding Tesla, which is also an AI that's driving down the 401 and taking people out randomly, all of which will impact overall survival, but they're all very different aspects. And so when we're thinking about the data sets that we're going into our AIs, we have to recognize that they're going to be imperfect in many situations and won't be able to deal with this sort of complexity. And so we have to understand that. The interesting part for me is that in radiation oncology, we have probably one of the best AI environments. Radiation oncologists, myself included, live in the imaging space both during treatment planning and delivery. So everything I do is effectively either done on an image, which is a digital representation of a patient, or subsequently treated in a trackable digital way. The only thing that I do that isn't in one of our electronic systems is the physical exam. Everything else fundamentally is encapsulated in some capacity in one of our treatment systems, either the treatment planning system, the delivery system, our imaging space, or the medical record in the sense of pathology and staging and all those things. And as a result, almost everything about the way I treat patients is accessible to an AI. And so the data that I put into the medical record or generate as part of my treatment of patients, an AI would have almost complete access to that same stream of information. And so it's a very interesting sort of environment for development of AI tools because it has the potential then to be implemented to supplement or augment my decision making in a standard radiation oncology practice. And so this is the sort of stuff that we're thinking about in radiation oncology. And for those of you who don't know, radiation oncology is just I give radiation to patients who have cancer mostly. There's a few patients that don't have cancer that get radiation, but radiation is kind of a cancer thing in most situations. But there's general automation, the review of medical records, generation of radiation treatment plans, including time sensitive and human intensive efforts like contouring all the tumors within a patient to make sure that we hit those and miss the normal tissues, generating dose calculations and decisions related to how we match a patient to a given treatment on a given day. But there's also the other cancer high-level stuff, which includes prognostication about what happens to patients in the absence of cancer. Are they going to live or die based on their cardiac disease? Do they have other conflicting or competing risks that may make the cancer more or less important for predicting their likely outcomes? And then there's also the prediction of disease response to treatment itself or the toxicity of treatment. So if I know that a specific patient has a higher or lower risk of a cancer-related complication from a specific treatment, we may want to change or personalize their treatment based on those sensitivities to allow us to give a better outcome, i.e. better chance of cure or less chance of toxicity, or potentially both. And ensemble prognostication or personalization, including all of those features, is something that I think we're all kind of holy grailing about, because I think having a way to predict what the best treatment is for a given patient really hopefully will make everything better for the whole system, pretty much. So, but what is AI ML from a medical standpoint? It's just a stupid digital system that takes an input and gives an output. It's that model in the middle that makes the transformation, but it's fundamentally very similar to a laboratory test or a radiology study or a clinical decision tool, all of which are things that we are as medical physicians or members of the healthcare team familiar with using. We all know how to interpret a CBC because we've been told how to do it. And so we have to learn how to use AI in the same way, and we need evidence to do that. But the problem is there isn't a lot of good data or good, well-deployed AI systems that have shown us how to do that. So how do we assess the efficacy of AI, and how do we develop this evidence within an institution or within the general community? This is my favorite paper, at least for the last year or so. It's been my favorite paper. It's a paper that was published in 1991 by Freibeck and Thornberry, and effectively it's a radiology paper, and it's looking at the levels of evidence for specific radiology tests. Basically, they've gone through and said, if I have a CT scanner, there's 6 or so levels of evidence that I need to develop to prove that that CT scanner is a useful thing. Level 1, it has to be technically efficacious. It has to actually take a good picture. That, grayscale ranges and sharpness and seeing things. Level 2 is, does it help me actually see a disease? Does it help me see the tumor? Does it help me see a pneumonia? Does it help me see a problem that can be fixed? Does it help my diagnostic accuracy? Is it efficacious in that space? And that can include things like ROC curves or sensitivity and specificity in determining whether or not a disease exists within that image. Level 3 is, does it change the way I think about a case? So if I have a test and it says it's sensitive for a specific diagnosis and the test tells me it has that diagnosis, does the clinician believe it? Does it help me make the decision that the patient has a specific diagnosis that I care about? More important than that is, if I do believe that they have a diagnosis, did this CT scan help me make a good choice about what treatment to deliver? How often the presence of that CT scanner change my medical decision about what treatment I wanted to use or what treatment I should use? And then, more importantly, did that choice of different therapies change the patient outcome? Did it make more people live? Did it make more people have less toxicity? Does it save money per unit patient? And at the highest level, if you can show that this not only is a societal benefit, so overall it saves money for the overall medical system by using CT scans for a specific circumstance, this is the sort of evidence spectrum that we want to have for a radiology test. But there's a completely analogous series of steps for AI. Level 1, instead of does it take a good picture, is does it actually identify features that we know are important for an AI to identify? Can it pull out a feature that we care about? Does it have a sensitivity or specificity for a specific diagnosis? Does it help me make that diagnosis using the AI or not? Does it change my decision making? Does the presence of the AI in the medical environment change the clinical decision that I'm going to think about making? And does it help me choose a therapy? If it does that choice of therapy with or without the AI show a difference in outcome, either morbidity, mortality, toxicity, or something compared to baseline? And eventually cost benefit is something that we want to think about for AI implementation in the clinic. But if you think about what this means, is that we start with a very basic level and we move up this chain of evidence. And there's a huge range of different places along here where you can develop types of evidence. But the majority is that there's actually a kind of a dividing line, kind of in the middle here somewhere. And below this line, we can do things with retrospective data, like old data sets that are built up in, from 10 years ago. But at some point, we actually need to start thinking about doing clinical trials where we're actually comparing the use or absence of the AI in the clinical space to determine if it's actually going to make a difference in terms of outcomes or clinical decision making. And I think this dividing line in the evidence that we generate is an important decision as part of implementing AI in the clinic, because if you don't have this evidence yet, you have to set your system up to generate that evidence, but you have to know what you're looking for before you do that. And so it's kind of a chicken egg problem where if you don't have the evidence, you need to build it, but you don't know how to build it until you have the evidence, and et cetera, et cetera. So we'll get there. But the randomized trial really is the best way to test this. And the gold standard has always been randomized trials. In medicine, at least, it distills a complicated question down to a simple yes/no result: is does the addition of test X or model X or treatment X make people live longer or have less toxicity, or whatever the primary endpoint is of relevance? And as a result of a clinical trial, a randomized clinical trial, we should change the standard of care. And everyone's supposed to accept the result, but we know that we lose a ton in a randomized trial. We lose the high dimensional complexity. We know that there are some patients on randomized trials that aren't well served, that in fact are probably hurt by the choice of the general treatment benefit. And in many cases, this is a throwaway set of data. We can't really reuse a clinical trial because it's hard to collect the continuous stream of data that's necessary in most situations. And so we can't ask the same question with those same patients that we've already done. And clinical applicability is an issue, because in many cases, the patients we enroll in clinical trials are different than the general patients that we see in the clinic. So if I have my 35-year-old who's in otherwise perfect health, and I put them on a randomized trial and I get a clear result, and then the next day in my clinic, I see a 75-year-old with like 7 medical comorbidities, I have no idea if that randomized trial is directly applicable to that specific patient or not. And I think that's something we recognize as a flaw in a randomized trial, but we have to think about that also in the context of these database things. So here is a good trial. I like this trial. I use this trial as an example in a lot of situations. This is a hype trial, which is basically the best name possible for an AI trial. This was done back in the Netherlands about 3 years ago or 4 years ago now. where they basically built an AI to sit on the anesthesia machine in the OR and just watch the data. And they trained it to basically anticipate patients who were going to have a bad day, who were going to get hypotensive, who were going to have an event, who were going to need an intervention. And effectively, they developed a model here that you can see that predicts at 5, 10, and 15 minutes before an event with a very high degree of sensitivity and specificity that something bad's going to happen to that patient. And then they did a very simple thing. They took 30 patients per arm and randomized them to turning the AI on to have a flashing light or not. And I say that kind of facetiously, but effectively, they let the AI run in the background in every patient, but they only turned the alert on, which is to say they only notified the anesthesiologist half the time if the AI triggered. And so what does this mean? This means that they're intervening in the standard of care in a seamless way. They're collecting data that's already present in the stream of care, and they're basically randomizing just the notification part. Everything else is the same in these patients. The AI arm had less hypotension, less chance of hypotension, faster reaction to the anesthesiologist to events that were coming, and less serious events. This is like a friggin' win, because the AI basically told the anesthesiologist to wake up a few minutes before they actually needed to wake up to prevent whatever was going to happen. And maybe it's just the fact that it started flashing that they stopped playing with their phone, or I apologize if there's anesthesiologists in the audience, but fundamentally, anesthesia is a very tricky job because you have to be constantly alert, and that's hard for humans. Having somebody in the background who's perfectly alert all the time, this AI, and is willing to give you a little nudge in the foot when something's coming, is actually exactly what this sort of tool is designed for. So why is this awesome? This is awesome because it used a previously validated sensitive specific tool, that Fryback and Thornberry level 1 data that said this thing is efficacious. It technically does what it's supposed to do. It compared it to a standard of care. The same data was present in both arms. Only the difference was the AI was turned on and flashing its light or not. And the endpoints were specific in how they addressed the patient outcome. So they talked about reactions by MDs. They talked about specific endpoints that are relevant for this specific environment. And it addressed the direct impact on patient outcomes. It showed that patients did better. They survived more likely. They had less chance of hypotension. They did better in surgery. This is a clear win for an AI use case in this environment. And this is that Fryback and Thornberry level 4, 5 stuff. This is where you need to do these sorts of tests to prove that it actually intervenes and makes a difference in patient outcomes. I love this paper and I love this idea. The problem is we don't know if this works anywhere else in the world outside of this one OR. And maybe it is the case that this is something they can like hardwire into every single anesthesia machine, but we don't know that. And that's where we start to get into the complexity of what happens when you start thinking about AI systems that are developed at one center and potentially applied in another one. What are the drawbacks, right? These sorts of trials cost money. The single question problem is a real one. And this is hugely challenging in some regulatory environments because AI regulation is in and of itself a moving target. If I have an AI on Tuesday and I get 10,000 more patients on Wednesday and I have a brand new AI model on Thursday, do I have to run that randomized trial again? Like, that's a real question. Is the model that much different that we have to consider reassessing the entire validity of our process? This iterative nature of AI, where I can continuously train and get a different behavior, a different responsiveness from the system, does raise the question of how you're going to implement AI, how you're going to test AI, and how you're going to use it. And I think that's something that we're talking about regularly. So what do we do to address this? The most important thing is that any data we're collecting, we should be making the data part of the results. So we should be, big data randomized controlled trials should be standard. We should be releasing the data for all of these patients as much as possible so we can reuse this and hopefully make this a part of our overall system. And so this is that efficacy testing spectrum. And again, if you haven't read this paper, it's worth it. They have amazing florid language and they do a really good job of explaining the concepts. Please go back and read this just for funsies. Eventually, I'll publish the AI version of this just for fun, just to have it in the literature. But this one's a great read just as it is. So you guys have heard about real world data. It's just the stream of data being generated by patients. And that includes EHRs, billing, claims, disease registries, all the stuff that we're talking about and Shaft's in charge of at the hospital. We currently know we collect it, but do we really have access to it? Is it really optimized for research? Probably not. Most of it's missing outcomes, most of it's biased. In many cases, there's lots of embedded treatment effects that are very difficult to deconvolve. And the amount and the variety, velocity, and veracity of the data is very challenging. We are generating, this is now a year or two ago, the medical data is like in the exabytes per year. And now it's going to be by 2025, we're talking exabytes per day. So think of that's, most of us can't even imagine what an exabyte is, much less the fact that we're generating hundreds of millions of these per year. And figuring out what portion of that is relevant for AI generation is very important. And so we'll talk about that a little bit later. But getting back to these models, I want to show you some of the stuff we've been doing in the department here to try to generate some of this information and try to convert this into clinically relevant stuff. The nice part and the cheater part that I have is that, as I mentioned, my entire universe is already digitized. I already have low-level access to all of the data that I'm going to be showing you in real time because we've built it that way. So let's go through some of the radiation treatment planning aspects, and I'll talk about, first of all, contouring. This is a job that I do every day. I get to draw circles. This is my favorite job. Shaft's jealous of me because he has to draw circles with a knife. I get to draw them with a mouse. And I basically spend 1 to 2 hours per case drawing circles on a patient and planning out exactly where I want to put the radiation. And fundamentally, I spend a lot of time doing this. And that time I spend doing that is definition. I'm actually classifying for each patient tumor versus non-tumor and deciding what I want to treat. This is my mental decision process, the same process that Shaft makes when he's cutting someone open. I'm actually doing it in a digital format, and people can track and trace exactly what I've decided. There's hundreds of AI tools that are in process to auto segment or auto contour patients, and there's automation in place to generate the appropriate names and nomenclatures for this. What we've basically worked on is kind of moving beyond the fact that there's a commoditization of the models now. I think there's so many auto segmentation models in place that there's really another step that needs to be done, which is you have to basically figure out how to compare them in a clinical environment. And so you have to basically have something that is a data set that we have curated. You have to curate models. You have to do the model training and then do a performance comparison and assessment with clinical acceptability. And so what we've done is actually compared in a recent paper, this one did, I think, 10 models, where we trained them all against a given set of existing data, compared it to our outcomes, which is the clinically relevant outcomes for these patients in terms of their actual contours that were used clinically. And we showed for some structures, for instance, easy structures like eyes and larynxes, these almost all the models do well. But for smaller and more complex structures, UNet, specifically Walnut, was the best model that we could train on for this existing use case. But there's probably better ones. I'm sure Bo Wang and other people who are developing these sorts of segmentation models have already generated the next gen models that we haven't even seen yet. But we have to have a structure and a way to compare them. And so in our system, we actually do end-to-end real-time comparisons of these things where we put these things into patients. They're auto-segmented, and clinicians can choose which of the models they prefer for that patient on the day, and we track which ones they like the best. And then if they edit it beyond liking that, we track that too. And so we're continuously identifying the optimal, i.e. the highest quality models for each patient. And we're doing a comparison in real time in the clinical stream of treatment. We no longer are doing standalone comparisons. We're going to be doing these in real time as we're treating patients. And so we've got this framework. We should be going live sometime later this year, and that's part of our scalability grant that we've received from the CDI, is to try to generate this not only for head and neck, but for other sites to allow us to compare these sorts of contouring models for all sites in the radiation oncology space. What's interesting is that we know that these things don't work in every data set. So if I develop a really great contouring model from my center, and I look at other people's contours from other centers, my models don't work because they draw things differently. They make different decisions about what the edges of tumors are, what the edges of normal tissues are, which underlies a fundamental problem of what is the gold standard in this sort of space. There is no gold standard. Just like in surgery, where someone makes the cut is a surgeon's choice, in many cases where someone decides that the edge of the tumor is in radiation oncology is also a specific clinician's choice. And the only way to know if we're right or wrong is to fundamentally look at the outcomes. but we can do that because we know digitally exactly where those decisions were made. And so we can have a exact comparison of what happened to someone based on the decision of where the edge was. We can do the same thing with models. So if we have 10 different models and we apply them, we can actually track that forward in time and see which of those is correlated with which outcomes. And we will be able to determine which ones are most likely to be the most beneficial for a given patient. What's interesting is that if you're measuring clinical acceptability, clinicians are biased fundamentally. We did this experiment where we took human models, human contours for things like eyeballs, and called them AI models and told people randomly that they were either human or AI models. And the patients, the clinician observers who looked at these things, who were told that human contours were AI, they ranked them lower because they thought that they were AI. Even if they were exactly the same clinically accepted human contours, there's a fundamental bias in the way that we identify or believe that AI should be better or clinician-reported outcomes should be better. And so I think we have to figure out ways to blind our own qualitative observations to the source of this to be able to deconvolve this AI versus clinician contouring problem. But this doesn't apply, the biasing issue just doesn't apply in contours. Chris McIntosh and Tom Purdy and a bunch of our prostate colleagues at our institution have developed and deployed a model that actually auto plans patients for prostate cancer. And this made a big splash about 2 years ago in Nature Medicine, where they showed that the auto segmentation, the machine learning outputs, were effectively equivalent to the clinical output and saved a ton of time. But they had to do it in a randomized way, because if they showed the clinicians which ones were which, the clinicians would always be biased against the AI. And this is interesting, but I think this sort of model where we save time in contouring, we save time in planning, saves us a ton of time. So this is the human-generated radiation plans versus the machine learning plans. We save an average of close to 80 hours of human time when we have an ML-based plan generator. A really big chunk of clinical time, and that's like an FTE basically if we have enough patients. Hugely different. 71 hours per case effectively is a big deal. And so this sort of acceleration is going to make throughput in radiation oncology a lot more interesting and a lot more relevant. So those are some of the tasks that we talked about. I'm going to just touch on the personalization or the prognostication aspect. And I think the one that I like is, uncomplicated tumor control, which is the combination of background diseases or responses to treatment. And what we really want to do is personalize this, but we need a model to do that. And so we've published now this is now, I didn't update that reference, darn it. So the archive is still there, but there is actually a CRC publication on this now. But basically, we published a challenge where we took 2,500 patients with head and neck cancer and split them into training testing and showed people the training data so they could develop models to try to predict which patients were going to survive. And then we tested on the held out data set, the extra 750 private test. And anybody could submit a model within the institution. And we got a whole host of different models. All sorts of baseline things, including volume and radiomics and clinical features, were included. But the combinatorial models, including models of electronic medical record information and radiomics, generally performed slightly better than those that included things like volume or just radiomics alone. And that's because there's a lot of interesting features that are embedded in the clinical data. What's problematic about this is the same thing that's problematic about models for contours. If you take them, those nice best 3 models, and you take them to different data sets from around the world. This is from Montreal and this is from Poland, Texas, and Montreal. Suddenly, the models just fall straight off. The best models performing here still perform probably better than many others, but you can see that the AUC ROC drops off dramatically. In some cases by close to 0.2 or so, like a big drop in performance. And that's because these are different patients with different features, and we've probably overtrained our models internally. And so this is the extensibility problem, and figuring out ways to train models that are going to avoid that is a big deal. And we don't have a fix for that yet, but we're working on federated models that are hopefully going to be able to cross between different centers to figure out how to deal with this variability. So let's classify some AI for clinical deployment. Low risk is things that are gated, things that it's going to eventually trickle up through the clinical staff. It's assistive. It's not intended to affect clinical decisions straightforwardly, but it is, potentially helpful. It's automated in some ways. That's Wally. I like Wally. Medium risk is it can affect clinical decisions, but not independently. It's partially gated. So things like clinical decision support. So it may influence your clinical decisions, but it's not going to do it autonomously, hopefully. And we've all seen C3PO get into some trouble. But I think the high risk ones are unsupervised AIs within the clinical environment. This is the Terminator stuff that we have to worry about, where an automated system is designed to trigger a clinical intervention without clinical oversight. And I think these are pretty rare. But the thing I wanted to start with is one of the ones that we've built that we think is still low risk, but it's relevant. So let's go there. So this is a paper that we're in the process of getting published that we presented in abstract form earlier this year, where we basically developed a model to test for ILD in our cancer patients. And so ILD is a very simple disease in the sense that it's a bad thing to have. It makes your lungs worse. It's more common in patients with lung cancer, and it increases the risk of all sorts of treatment. So if you have background inflammatory or interstitial lung disease, you have worse surgical, worse chemotherapy, and most importantly for me, worse radiation therapy outcomes. You have a bigger chance of radiation pneumonitis and a much higher risk of long-term mortality associated with this. Shaft doesn't like these patients. I don't like these patients. These patients are bad because they do poorly with all of our treatments. The problem is that most of these patients come to us in some capacity diagnosed, either from clinical symptoms or from their diagnostic imaging, but not all. And right before we're going to give radiation, there's one other time when we have a chance to look for this, and that's on the radiation treatment image. If I have a radiation treatment image, I actually have a full CT scan of this patient that we could potentially, right at the time of treatment, interrogate to see if there's any evidence of ILD. And so that's what we tried to do, is we tried to build a model that would interrogate this specific image within our workflow in a clinically relevant timeline and give us some feedback right then to ask the question, is this patient likely to have ILD or not? And so we got some funding from the CDI Grand Challenge to do this, and it's really just to look at that specific use case. As is always the case, we have a black box. Everyone has a black box, right? That's what AI is. And I tease because fundamentally it's just taking the CT image of the plan, putting it through the black box and generating a score. Under the hood, there's actually 2 or 3 steps that we're doing, which include an auto segmentation tool, just like I talked about before, and a classifier that took that auto segmented lung tissue and tried to estimate the risk of there being actual, ILD features within it. We've got segmentation of lung tissue and a VGG16 in 3D. Chris McIntosh can go on forever about how he did this exactly. Fundamentally, for me, it's still a black box because I could just apply it to the image. And that's what we did. We basically took initially about 4,000 diagnostic CTs with and without ILD classification, trained a model, and then tested it on our planning CTs, and it really didn't work very well because there was a lot of bias in this underlying diagnostic data. We transfer learned and retrained on the planning CTs to make sure that we had better planning CT specificity, and then retested that model on another 200 patients once we had the 500 to train on, and then validated that this worked to some degree. This was the initial performance that we had, about 0.75, which we thought was better than, it wasn't great, but not terrible. And it was better than what we had at the time, which was nothing. And so we started basically running this in the background once we figured out what threshold we wanted. And this is the important part of, for us, how we use a model in the clinic, is making the decision about how you're going to decide what test makes this positive or negative. We estimated that this threshold, would give us about a 15 to 20% false positive rate, but would catch about 60 to 70% of the cases, at least. It wouldn't trigger on every patient, but it would trigger on enough that it would hopefully be able to tell us when we had a patient that had a high probability of ILD coming through the system. And so given this baseline, we then deployed this live in our environment using a tool we call Mira, and I'll talk about that later. But basically that model, that threshold model, was then applied prospectively under a prospective quality improvement framework on every patient, and it was done nightly. Every patient that got scanned for radiation automatically was added and processed via this model, And then we had 2 planned intervention phases. One was silent and one was live, where the silent was just like in that hype trial. It ran in the background, it gave a result, but it didn't tell anybody. And then once we had reviewed the results from the silent, we were planning to go live and start sending out the notification to people so people would react in whatever way they thought was clinically most relevant. Every single patient on this prospective quality improvement study was expertly reviewed by one of our thoracic radiologists to determine what their actual ILD status is, so we would know what the performance in the model was in the real world. This was all done using the Mira framework, which is actually in-house custom software that runs within our planning system on a dedicated server. It has access to all of the radiation oncology environment, as well as the PACS and some other kind of distributed web applications to allow us to interface to that. And so we started running it back in 2020, or 2022. And over the course of the spring and summer, we accumulated 180 patients. And this was the performance. Basically, about 15% were flagged by the AI. There was a 5% prevalence of the disease within our cohort, and we caught, of the 9 that were in there, we caught 6 of them with our system. So the AI correctly identified a majority of the patients with ILD and would have triggered if we had had the notification turned on. And so after we saw this, we were like, yeah, we would like to know the 6 patients with ILD. It turned out that actually some of those were known to us. So Shaf had sent me some ILD patients to treat with radiation because he didn't want to do surgery on them. And so of the 4 patients that were not known to have ILD, we caught 50% of them. So 2 patients would have been caught had we had the system turned on live during the silent mode. So we turned it on. And so once we had that, the performance and the model was looking very good. And then we turned it on. We started sending these silly emails because that was the system we had at the time, because this was pre-Epic. And basically, with no other changes, we just started sending out emails to people that said, "Hey, Drew," or "Hey, whomever patient MRP is, your patient might have ILD." And it talks about what the false positive rate is. It talks about who you should contact if you have questions. It gives you some information about that, but it basically sends you a flag that says something's up. And so we wanted to have people fill out, surveys about how likely it was that they were happy with this and what their experience was with the system. So there's a feedback system to do that. So once we turned it on, we collected another 250 so patients with a very similar sort of performance. About 15% were flagged. Of the 13 that were identified in the group that had ILD, we caught 7 of them, and we caught just under 50% of the patients that were unknown with ILD. So realistically, we identified 3 patients with ILD that would not have otherwise been known to have ILD before they went through radiation. And those 3 patients were able to be intervened on by the MRP to decide if they really wanted to proceed with treatment, knowing there's a slightly increased risk in that subpopulation. Similar performance, 0.72, 0.73. And this summary output of this prospective validation showed that we caught, of the 5% prevalence, we caught almost half of the patients with ILD that would have otherwise been missed using this system. And so for us, this was a big win. These are patients that we otherwise wouldn't have known about or wouldn't have been informed about that were caught by this AI system, and we wouldn't have otherwise been able to do anything about them. We've looked at subsets, and it seems to work a little bit better in the SBRT patients, but we're still working out ways to improve the false positive rates in the patient subsets that are a bit more complicated, like locally advanced lung cancer. But these are advancements that we're working on. But the overall performance was very similar to our original estimate of performance, which was a AUC of about 0.76. And so we've I think we've validated clinically that this works for us in our environment with our infrastructure. And I think that's the important part here, is that this relied on interdisciplinary teamwork with the diagnostic radiology division, but it was a clinically acceptable workflow. The clinicians got to see this in real time. It was usable in real time, and it often or always gave us a result before the patient was treated so we could intervene if necessary. And this system is live. It still is screening patients every day. And I think that's what I wanted to focus on, is that the implementation here for us at UHN, we have to focus on infrastructure. And that's what Mira for us does. We have a place to put models. They live somewhere. They exist in the MONAI framework. We can upload new models at will. They have access to the data stream, including all real-time access to PACS, RayStation, Epic, other features, and they can produce a clinically visible result in email in some cases, but we're planning on methods to expose that data to Epic, either a research or a clinical capacity as deemed appropriate by the REVs, and by bioethics as well. There's some complexity there we can talk about. But this model result needs to be clinically visible, timely, and actionable. And most importantly, the model usage should be tracked and monitored. So we have frameworks that exist to show us exactly how many patients have been processed, how many have been triggering the result, and what our response was. And more importantly, we can actually determine if the model is consistently demonstrating similar outputs. Are we getting the same range of output values for the number of patients that we're examining? And what that means is that we're continuously monitoring the performance of this over time. And if we see a drift, we can intervene and potentially retrain the model if we feel it's necessary. So I think UHN as a total should really refocus on infrastructure, because building that infrastructure that allows people to deploy any and every model that we want to needs the infrastructure to develop data, but it also needs a place to put the resultant model and then develop evidence. And we have to have a mechanism to take those models from the data, put them back into the clinical system, and observe what it changes, how it changes, what outcomes change. And it's easy because we can always implement them in silent mode and just monitor, right? If we think we're going to improve time to discharge and we put a model in the background and let it run for 2 months and the output suggests that nothing is going to change, then maybe we don't turn that model on. But those are the sorts of things that I think we really need to think about within the institution, and especially within the clinical environment and in the clinic itself. And this interplay between the infrastructure and evidence is actually really important, because the better the infrastructure, the faster we can develop evidence, and the better the evidence, the more benefits and hopefully changes we can make to the infrastructure to make them even more impactful. So I just wanted to thank everybody who's been involved from the ILD side, but especially Tony and Tirth from the radiation physics and computer science side for developing and deploying Mira. Chris McIntosh was the majority of our computer science heavy lifting, and Sonia Kendall was the diagnostic radiologist that helped with all those ILD cases. But the CDI group and bioinformatics and radiation therapy, like, this is a huge team effort that to develop these models and deploy them. And I think this is we're going to need to have these sorts of multi-disciplinary teams to be able to make this work in the future. So be happy to take questions or ideas or disagreements. I'm happy to take those too, but happy to take any feedback.
Thanks, Drew. That was excellent. Very exciting work. People can ask questions. Just put your hand up, or you can put something in the chat. Drew, I have one question. We have a huge lung cancer screening study, and so CT scans are done and multiple scans are done. Have you just looked at that database to see how many you just pick up ILD early? Because there's treatment and clinical trials for those patients too.
Yeah. So this is where we're getting at, is the at least in the clinical side, the false positive rate is still high enough that doing broad spectrum screening of large volume things will generate a lot of false positive noise. So if we're talking 50% of 5,000 patients, that's an awful lot of additional screening or additional work that may need to be done to identify that subpopulation. And we can adjust that threshold.
Is that inaccurate? It's 50% of the patients.
15. So, but I think that is a question. Like, we could adjust the threshold and we could turn that threshold to be much more specific and less sensitive and still pick out a proportion of those patients that would have ILD.
No, I think that, it might cause some stress in some patients, but I think if they knew they were being screened for cancer and don't have a cancer, but that you see some changes that maybe you would want a respirologist to look at their PFTs and look at them, that might be, I think, something of interest to our interstitial lung disease clinic.
For sure. I think, when I ran it by Shane Shapira, he was a bit appalled by the idea, only because he's already saturated, right? If I told him I had an extra 100 patients a year, he just didn't have space for that, right? He's already seen extra consults on the weekends and evenings and everything else. If I throw an extra 2 or 3 new patients a week at him, I think his clinic melts. And that's one of the things that gets interesting, right? Screening.
I have an idea for that. I think we should move on that. It'd be very interesting. No, because these are patients that are hard to treat. They're lung cancers, and then they're also that ultimately end up coming to lung transplant. And then there's some very interesting and novel therapies where I think many of these patients would want to participate in the early treatment trials.
Yeah, the other question that we can think about is that whether or not these are radiographic only and may never become clinically significant is another issue, right? So like these are trained on radiographic identification, not clinical. And so, there may be a subpopulation of patients that have ILD-like changes that never become clinically relevant. And so we have to kind of think about that in the same way we do, low burden or low risk prostate cancer, right? I mean, we don't need to treat all those folks.
Yeah. David Wong has a question.
Thanks for this talk. This is, for me, that's amazing. I'm new to this space, but I'm coming at it from a different angle. Because every time I hear a medical AI talk, it's in the lens of imaging or pathology, but it's some sort of imaging. Whereas in my work, it's not. It's actually all numbers, and all of my work actually is mainly digitized. So I'm just wondering if anyone is working in the space of numbers, for example, the lab tests that you get in Connecting Ontario, because just with my eye, I can identify a lot of disease early. It's just that no one else can identify it because they're not aware of what to look for. And I think that's an easy something to train on to earlier identify diseases such as alcoholic liver disease.
100%. And I think that's the one thing that we have to basically do is identify experts, maybe like yourself, who can give us that signal. So if you can say, here's a set of lab tests that I always will think about a specific disease, and we have that real-time data stream, there's no reason we cannot train an AI that will do exactly what you do, which is to look at those lab tests and flag patients that are at high risk of having alcoholic liver disease.
Please have someone talk to me, because we see this and it's obvious, but it's hard to get people to recognize it.
Yeah, no, I think it's a great use case. It's a really simple one. It's probably one that's going to trigger the same degree of problems that I was just describing with Shaft, which is if we identify 1,000 patients with low-level cirrhosis from alcoholic liver disease, who do they see? Who do they talk to? What do we tell
we would
them?
have capacity for this. This would, because we're getting inundated with garbage, but this would be useful.
Yeah. So, I mean, easy to do. No problem.
Especially useful if there's something that you could do to benefit the patient with that new knowledge,
Well, there is. There's actually a study in the UK showing that earlier intervention actually prevents hospitalizations and deaths. So if we could, and I think because we have the infrastructure with OLIS, we could actually, if we could do, I just need someone to show me how to do this, and I think we could actually make a difference.
Yeah, no, I think that's a great use case. And, I think Kelly, I'm sure will be happy to identify a specific AI computer scientist that would love to collaborate with you on this. I think that the integration with the clinical part, that's a little trickier. That's an infrastructure thing that I'm saying we have, but I don't know that we have institutionally for UHN yet for all spaces.
Yeah. One of the challenges is we're not allowed to use Connecting Ontario data for research, right? So even though you know that on a patient, like to do that kind of a study is it's another thing, but that is a problem we can't do.
Yeah. We could still hypothetically train it on UHN specific data, and then you have that model available when you saw them clinically. But if you saw them clinically, then you could put in or access the OLIS or data once we have a model that's been trained internally. But I think
this is something where we actually should push back on Connecting Ontario and OLIS, because this actually is affecting the health of the people. And COVID taught us that privacy cannot trump healthcare, right? And I think this is another case of that.
Yeah, I think that's a gauntlet that we'll have to give to Shaft to chase at whichever windmill is necessary to chase.
The
same. I would love to talk. There's a guy in the UK doing something similar, and they got around it. But there are ideas.
Yeah, no, I think there are ideas, and again, if you launch it as a province-wide study where each patient could be consented, then I think that's the hurdle for that one. But it is a problem. So Drew, I was just wondering again about in terms of you're specifically using AI to identify risk of patients. Like I might send you a patient because they've got bad lung function, but then the CT might show that there's some early signs of IPF, and then you know that that patient would be high risk to treat with stereotactic radiation. So have you been able to look at that in terms of risk stratifying patients based on that image, or
Yeah, that's where we're actually going right now. So you've as I would expect, you kind of thought about what we were doing tomorrow. So we're actually currently looking at the correlations between the extensiveness or the height, the AI value that comes out of the AI model, i.e. how high that value is from 0 to 1, and looking at the correlation between that survival and toxicity as a way to specify, if someone's above a threshold but not really high, are they actually going to have toxicity? And we haven't sorted that yet, but there's a good chance that we're going to get some collaborative data sets from London Health Sciences and from Hamilton and a few other places to look at this in a multi-institutional setting to try to see if we can identify patterns that associate the severity of ILD with the ILD score from our model. And so it's a logical thing to do, and we're trying to do it, but we haven't gotten there yet. Jethro asked a question: how long was the silent trial conducted for? That went for about 4 or 5 months. So did the duration of the silent trial have to be specified a priori in the REB? No, and the reason was that we were enrolling all of these patients on the quality improvement study that we had discussed with them. And so we actually ran this up the REB, kind of IRB, REB cycle, and said, okay, this is all data that's available to clinicians and the radiologists, and we could look at it anytime we wanted to. The difference is now that the AI system is going to notify above a certain threshold, and they were comfortable with that not requiring like an REB level of intervention, because this is all gated by the clinician and it wasn't going to be exposed to the patients, and it was stuff that we already had access to. So it's an interesting question. I don't know how the REB is going to respond to trials as we go forward. I think there's probably going to be a variable REB quality assurance sort of spectrum depending on the risk associated with the AI, kind of the Wall-E C3PO Terminator level stuff. Because I think in the case where the clinician is going to get the result and interpret it, and it's stuff that they already should have looked at anyways, maybe we don't need to have REB for that, because it's just a reminder to the clinician. It's kind of like the kicking the anesthesiologist under the table to say, oh, you should pay attention. But I think that the choice for us of when to go live was based on the proof that the performance of the model in the clinical environment was equivalent to what our predefined estimates of the model performance were. So once we showed that it was performing similarly and it was doing what it was supposed to, which was identifying patients that were potentially at risk, we thought that that was sufficient, and then went to a live mode as a result of that. So hopefully that helps answer your question.
Yeah, I think your cartoon was really insightful, and there's a lot of things that people promise with AI. Like there was a company that said they put this little thing under your bed and will tell you two days before that you're going to have a myocardial infarction, and that company's out of business now because it did not work, or an asthma attack 3 days later before it was going to come. So I'm very interested in sort of saying, like, well, what is it that the monitor and the AI saw to alert the anesthetist that the anesthetist didn't see, even if they were paying attention? Like, what is it that they missed? What is it that we're missing? Because I think those are the opportunities, not to be instead of us, but to make us better at what we do. I think those are the kinds of things. And we're doing stuff like that with ex vivo lung perfusion. We realize there is so much data coming off that there are things there that we're not appreciating, that the machine is telling us, and can see subtle changes in the lung that we as humans are not seeing.
Yeah, I think the old rule, I think the old rule is humans are able to pay attention to 4 or 5 data points before our brain stops, right? And so, when we're talking data streams of hundreds or thousands of variables, humans just aren't built to interpret or, kind of monitor that level or that breadth of data on a regular basis. And so we will need augmented AI or ML tools to be able to help us to distill that down to the red light flashing, no red light flashing sort of inputs, because we just can't process that at that sort of bandwidth. So I think it's important to recognize that these will be augmented intelligence tools, not replacements or kind of complete swaps.
That's great. Are there any other comments or questions? Anybody? Not.
No problem. Oh, there's one from, is it, I don't,
Nope, there's somebody.
Dr. Sengar or Anita Sengar? Yep.
Yeah, so sorry, I'm Anita from the REB, and we welcome anybody to come to us and have the discussion because we're learning with you. So we actually would love to go through these processes and have the discussions, the bioethics component, the research component, the scientific component, so that we can all learn and go through the process with you and not be viewed as red tape or, obstructionist. We really want to move this aspect of research forward in the most smooth way, but we have to learn it as well. And it's going so quickly as you've described. But we really need to do it collaboratively. And we're happy to have people, reach out, please email me, and we can start discussions before submissions are put in, instead of, when thoughts are developing at that time, have the discussion. And then when the submission's ready to be submitted, we already have an idea of how to submit it and move it forward.
Yeah, no, I think the REB is integral. One thing I would actually ask you to do, Anita, if you get a chance, the Sick Kids REB has done a really, really cool thing.
Yeah.
Where they set up that parallel REB process for silent mode development and stuff that doesn't actually feed back to the clinic, just so people can run on clinical data streams and develop stuff. I think that sort of structure is huge. So having a fast track for silent mode monitoring studies would make everybody super excited.
So I think
David would be able to get
learn with that. Yeah, we'll learn through that. And we just need to get to that point. I've heard about it. I just haven't had the opportunity to explore it, but I appreciate you pointing that out. And I am fully aware of it. I'll reach out to Dave. Well, his name's David Kenny there too, the manager there. So I wasn't sure if you're talking about the same manager, but yes, absolutely. We'll reach out and learn that process and look into that model.
Yeah, that would be great, because then David Wong's, alcoholic stuff would take like 2 weeks to develop. And then he could, send that out to OLIS and everybody else the week after that. Once it just makes a lot of sense. If we're not doing anything that's going to hurt anyone, we're just looking at the data. I think that's a really good big opportunity.
Hey, I have LCAP, I have cirrhosis, I have Hep B. Like, it just goes on and on. And we can do a ton of stuff.
Yeah, no, Anita, thanks for speaking up, because someone from your team reached out to us too. And when they had AI related applications, to get experts to review it so we could expedite it and actually understand the issues, and we helped with that. So I think that was a really good move as well. And we're happy to help wherever we can.
Yeah, and I think the other piece, while I'm here and I have the audience, I would really like board members to be volunteer for the board for these kinds of projects, because they're going to come forward and we're going to need to understand the complexities at the board as a whole level. We appreciate that we can reach out to you, and that's fantastic on case-by-case basis. But I think as we move forward, it'll be integral to our board to have someone sit as a regular member.
I volunteer Shaf. I mean, he has nothing else on his plate, so I think he'd be a great member of the board. I tease Shaf, sorry.
We accept. Thank you, Andrew.
On that note, I think we better end this. We're close to the top of the hour, and thank you again, Drew. That was an excellent presentation. Really enjoyed it, and a good discussion too. Thank you.
Thanks again.